So, ma'am, we are on live and we are starting session, ma'am.
Yeah, sure.
So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's session is menopause and its management. I welcome the participants and I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Rahi Datta, ma'am. Madam has done her MBBS DGO and Madam is from Johar, Assam. Madam is currently the practicing obstetrician and gynecologist in clinic in Assam. So with this short introduction, I welcome you, ma'am. I'm handing session to you for your presentation now. Welcome, ma'am.
Thank you, Dr. Stalin. Good evening, everyone. Today, our topic of discussion is a very important topic, that is menopause and its management. I'm audible, no?
Yeah, ma'am, very much, ma'am.
Okay. Menopause, actually, women's health is a very important topic because the health of a woman depends upon the health of the entire family and the society. And in the menopausal period, it's a very crucial period in the life of a woman. And because the life expectancy has increased, actually 1/3 of the period is the menopausal period. So it's very important to increase the quality of life of the women during this period. And as it is said, it should not be the beginning of an end. It should be a beginning. So with that, I start today the presentation. Now, firstly, what is menopause? The definition of menopause, it is a normal natural event defined as the final menstrual period, which is confirmed after 1 year of the absence of menstrual bleeding. It represents the permanent cessation of menses, and it is the result of the loss of ovarian follicular function. And naturally, the average age of menopause is 51 years. And sometimes there is premature menopause due to bilateral oophorectomy, that is surgically, or due to chemotherapy, or maybe due to impaired ovarian function. And which is called, and sometimes there may be premature ovarian failure or premature ovarian insufficiency. Next slide, please. This is a staging system of menopause. That is the stages: the reproductive phase, the menopausal transition, and the post-menopause. Nothing much to discuss about this. Next slide, please. Okay. Now, while the life expectancy has increased, surprisingly, the age at menopause has remained constant. It has not changed much over the years. Next slide, please. Okay. Now, the hormone levels at menopause. How do the hormone levels at menopause change? As we all know, the circulating estrogen, which is the most important hormone for a healthy female life, there is decrease in the circulating estrogens. The ratio of estrogen to androgen decreases. Sex hormone binding globulin also decreases. And there is increased peripheral aromatization of DHEA to estrone. And testosterone level does not change significantly, it remains the same. And reversal ratio of estrone, estradiol to estrone increases. Next. Now the estrogen receptors in the body, where are they located? What is the effect of depletion of estrogen? As we are saying that the estrogen levels decreases, so what will be the effect of decreased levels of estrogen, and where are the estrogen receptors actually located in the body? So let's see, where are they located? Number one, brain. Estrogen receptors are located in the brain, and as the estrogen level decreases, so the women experiences hot flushes, insomnia, irritability, mood disturbances, dementia. Then number 2, breasts. As we all know, the breast atrophy occurs due to decrease in estrogen level. Estrogen receptors are also located in the eyes, which decrease in the level of estrogen leads to macular degeneration. Then the genitourinary tract. Now, what happens to the genitourinary tract? There is vaginal atrophy, there is stress incontinence, and as the lubrication decreases, so there is dyspareunia. Then effect on the heart and blood vessels. There is increased risk of cardiovascular disease. In the liver, changes in the lipid profile, and ovaries, as it is very evident, there is follicle depletion. And one most important thing, osteoporosis in the skeletal system and atrophy of skin and hair. Next slide, please. Now, types of estrogen receptors. There are basically two types, alpha and beta. Next. Okay. Now, the distribution of the estrogen receptors, alpha and beta, which type of receptors are located in which organs of the body. Now, as we saw in the last slide, that there are two types of receptors, alpha and beta. So in the CNS, that is brain, just now we have seen in the bone, heart, breast, ovary, uterus, testes, both alpha and beta receptors are located. In the liver, alpha receptors, and in the lungs, kidney, bladder, and intestines, the beta receptors. Next slide, please. Okay. Now, what are the effect of estrogen at various sites in the body? As we have seen that estrogen has effects on various organs of the body with the because the receptors are located in the various organs. So what effect does it do to these organs? On the bone. On the bone, the effect of estrogen stimulates increased deposits of calcium into the bone. So what happens? There is increased bone density. So the effect of depletion, estrogen depletion in menopause is the bone density will decrease, and this will lead to osteoporosis. This we all know. So what happens that only a trivial fall can lead to fractures in menopausal women if this calcium is not replenished. In the brain, it blocks the release of ovarian estrogen. So the depletion will lead to hot flushes, as we have seen in the earlier slide, sleep disorders, mood changes, then problems in memory or maybe Alzheimer's disease. Then on the breast, estrogen stimulates the growth of breast tissue. So increased risk of breast cancer and increased risk sensitive if there is so it is seen that it was seen earlier that hormone replacement it led to breast cancer. And what will happen if there is depletion in during menopause? So the breast atrophy, as we discussed just a few moments back, so there will be breast atrophy and smaller breasts. Then blood clotting and blood fats. So there is increased risk of blood clots. Then in the skin, fat deposition, there is increased fat deposition, which leads to softer skin. So what will happen in the menopausal age? The skin will become thin and dry. Then in the uterus, as the uterus will become, the lining will become thin, so there will be no periods, and the uterus will atrophy. The size will become small. And vagina, in the vagina, the blood flow will decrease, so there will be dryness. Vaginal infections will be more. Sex will be painful, that is dyspareunia. There will be incontinence of urine and pelvic weakness. Next slide, please. Okay. So again, what will be the short-term and the long-term manifestations of estrogen depletion? over time. Uh, so that is the graph. It is showing the um, development of subclinical disease. Okay, the estrogen loss and the manifestations of health risk over time. Next slide, please. So this is what just we have discussed these things: hot flushes, mood swings, cardiovascular symptoms, osteoporosis, cognitive disease, uh, and what will be the okay, okay, next slide. Okay. Now the physiology of menopause. Why does menopause occur? What is the physiology behind it? Now, as we all know, each ovary has a definite number of oocytes at birth, and year after year, uh, as there is ovulation and rupture of the follicle, so the number of oocytes decreases, and approximately at 50 years old, all the oocytes become exhausted. So this is the physiology behind menopause. So when all the oocytes are depleted, so there is stoppage of menstruation. So during the perimenopause follicular activity phase, estrogen levels decrease, and the pituitary gland produces increased amounts of LH and FSH due to negative feedback. As the estrogen level decreases, so LH and FSH increases, luteinizing and follicular stimulating hormone. The cycles become anovulatory, follicular development stops, and endometrium is no longer stimulated, and there is amenorrhea. Next slide, please. Okay. Now, mm, a natural menopause occurs as you get older, and as the ovaries stop producing eggs and makes less of the female hormone estrogen. The symptoms you are experiencing are due to low levels of estrogen. It signals the end of the fertile phase of a woman's life. But remember, not the end of a woman's life. It is just the end of a fertile phase of the life, and hence we are discussing today the management so that we can give a better quality of life to the female who are experiencing menopause. And these effects of estrogen depletion, as we have been discussing from the beginning: headaches and hot flushes, then risk of cardiovascular disease, backaches due to osteoporosis as the bone density decreases, so backaches. Then body and pubic hair becomes thicker and darker. Okay, bone loss, hair becomes thinner, breasts droop, as we have already discussed, nipples become smaller, we have discussed, skin becomes rough, drier, we have already discussed. Then stress or urge incontinence, this also we have discussed. Vaginal dryness, itching and shrinking, we have already discussed. Next slide, please. Okay. Now, symptoms of menopause: natural history, menstrual irregularity. Okay, the symptoms. Symptoms also we have been discussing in the previous slides, but let me just give an overview. First symptom is the uh, stopping of the menses. That is, symptoms start and increase from 2 years prior to the final menstrual period, peak at 1 year following it, and return to normal after 5 years. Okay, the symptoms varies widely. The first symptom, as it is very evident, is menstrual irregularity, that the periods will become irregular, uh, say at an interval of 2 months or 3 months or 6 months, like that. Then hot flushes and sweats, as we have already discussed. Sleep disturbances, we have discussed. Vaginal dryness. Then urinary symptoms, mood changes, loss of libido, we have just discussed. Osteoporosis, as estrogen leads to increased bone density. So osteoporosis, there will be decrease in bone density and osteoporosis. And cardiovascular disease. Then, okay, the menopausal symptoms, it says they are usually self-limiting and they last between 2 to 5 years, but they may also last longer. And menstrual irregularity, the length of cycle, as just now I have said, may shorten or lengthen. Some patients may experience this heavier bleeding and some may experience amenorrheic periods, and others may experience heavy bleeding on the contrary. So it may vary. And hot flushes. Uh, Hot flushes means sudden feeling of heat in the upper body, especially in the face, uh, and sweating, and it lasts for a few minutes. There are sleep disturbances due to night sweats and irritability, mood problems, and also problems in memory. And vaginal symptoms, as we have discussed, there is dryness, dyspareunia, itching, and recurrent UTIs and all that. Okay. Next slide, please. Okay. Now, till now, we have been discussing the which is the natural menopause. But now, again, one thing, there may be premature menopause. As we have seen that average age of menopause is 50 years, but if menopause occurs before the age of 45 years, then it is defined as premature menopause. Now, what may be the reasons for premature menopause? Why is it occurring before the average age of menopause? The reasons may be primary ovarian failure, then surgically induced menopause. That is, we need to do hysterectomy sometimes for fibroids or some other reasons. Radiation induced, if the patient had to go for radiation for some CA or something. Then chemotherapy for like CA and all. Then may be also linked with lower socioeconomic status. And then how it has to be managed uh, with HRT. Uh, we have to prescribe HRT. Actually, the term HRT has been replaced by MHT because when we give insulin, when we give thyroid hormones, we do not say insulin replacement or thyroid replacement. So why hormone replacement? So this term has been changed to menopausal hormone therapy instead of hormone replacement therapy. We have to start menopausal hormone therapy, and it has to be stopped at the menopausal age at age 50, that is. And um, then so that is this slide is about premature menopause, that is before the age of 45 years. And primary ovarian failure, it may occur at any age, and usually there is no cause. No cause could be elicited. It may be linked to chromosomal abnormalities or autoimmune disease, and it affects 1% of women. And 15% of women with primary ovarian failure may retain intermittent ovarian function for years, and spontaneous ovulation and pregnancy also. Okay, next slide. Okay, now how to manage. We have talked about natural menopause and also premature menopause, and now coming to the management. Now the management, in the management there are uh, it is a broad spectrum. Number one is reassurance, and number two, education and lifestyle changes. Number three comes the hormone replacement, or the newer terminology, menopausal hormone therapy, and there are also alternatives. So let's see what are the things in the management. Next slide. Okay. So coming to lifestyle changes. What lifestyle changes will lead to the relief of the symptoms, menopausal symptoms? So the hot flushes and night sweats. How to get relief of hot flushes and night sweats? By regular exercise, lighter clothing, to sleep in a cooler room, by managing stress, and by avoiding the triggers. And sleep disturbances, how to deal with the sleep disturbances? It says that avoid exercise late in the day and maintain a regular routine, so that uh, these will help in sleep disturbance, so that so that she gets an adequate sleep. Mood and anxiety, how to stabilize mood and how to reduce anxiety? By taking adequate sleep, by doing regular exercise and relaxation exercises. And for cognitive symptoms, adequate sleep and by regular exercising. And what are the triggers? Like I have said, that avoid triggers. Now, what are the triggers? Triggers are the spicy foods, caffeine, alcohol, smoking. So we have to avoid the triggers. And smoking and obesity are also increased with increase in hot flushes. Next slide, please. Okay. So now, so that was about the lifestyle changes. Now about HRT, or as I said, MHT, menopausal hormone therapy. Now, hormone therapy should be a part of an overall strategy, uh, and including it should also include diet, exercise, smoking cessation, and decreasing the alcohol consumption, and maintaining the health of peri and postmenopausal women. HRT should not be recommended without a clear indication for its use, that is, significant symptoms or physical effects of estrogen deficiency. Postmenopausal HRT is not a single regimen given to a standard women. HRT should be individualized and tailored according to symptoms and the need for prevention, as well as personal and family history. So many things have to be taken into consideration while giving HRT. In the 97, 98, HRT was, as far as I remember, it was given very extensively. I have heard about it actually. We were like small at that time, but as we read the history, we came to know that this HRT was given very extensively at that time. And then came increased incidence of breast cancer and endometrial cancer and all. So then again it was stopped. So many controversies regarding hormone replacement therapy and treatment therapies in uh, menopausal in menopause. But now again HRT has been started, but as just now I have said, it has to be tailored and it has to be individualized. It is not mandatory for the duration or what therapy we'll use. It is not the same for each and every patient. It has to be individualized and tailored so that to handle the problems of each and every women. Next slide, please. Okay. So, okay. Mm. Just now, no, what I have said, just now, this thing I have said, that there is no mandatory limitations on the duration of HRT. And whether or not to continue therapy, it has to be just like just we have discussed it. It is tailor made, and the physician will, the health professional who is dealing with the lady, he will decide whether to continue it. What will be the duration, what will be the dose, and there are different medications. Whether to give combined therapy or to give single therapy, it is to be tailor made and it has to be individualized. Next slide, please. Okay, counseling. Now, that is again one important part in the menopausal hormone therapy, that is the counseling. So, women which are taking the hormone therapy, they have to be counseled yearly. And this will include a physical examination, a medical and family history, laboratory, what are the investigations, what we require, and some imaging investigations like these x-rays and mammography and all, and discussion on lifestyle, very important, and strategies to prevent or reduce chronic diseases. So that is one important aspect of the hormone menopausal hormone therapy. Next slide, please. Okay. Now, what are the indications of hormone replacement therapy? Because as we have discussed earlier, that the menopausal syndrome, it is self-limiting. So within 2 to 5 years, the symptoms subside by themselves. So each and every woman does not uh, mandatory. It is not mandatory that each and every woman has to take a hormone replacement therapy. So what are the indications now? for the relief of menopausal symptoms, then for the prevention of osteoporosis, and to maintain the quality of life. Now, the quality of life has been to improve the quality of life. It has been a very um, important thing in today's life, because today women is very active, both outside and inside. She is working, so to increase her quality of life, it's a very important thing. And special groups of women to whom this hormone therapy has to be prescribed are, as we have already discussed, those with premature ovarian failure, that is less than 45 years, then gonadal dysgenesis, and surgical or radiation menopause, that is due to surgery or due to radiation. Next slide, please. Okay. Now, what are the benefits of the hormone therapy? The benefits are that in treating the vasomotor symptoms, that is, vasomotor symptoms means hot flushes, uh, night sweats, and urogenital symptoms. Treating urogenital symptoms, the UTIs, dyspareunia, then vaginal dryness, these things, and treating sleep or mood disorders associated with flushes and night sweats, preventing osteoporosis. Then this is very important, and reducing the risk of colon cancer, and improving the quality of life and sexual function in symptomatic women. Next slide, please. Now, as I have already said, that the menopause hormone therapy has to be individualized for individual women, and what type of therapy to be given to which type of women. So, with uterus, that means with uterus means the women who has an intact uterus, what type of therapy to be given to them. In the perimenopausal period, we generally give cyclical combined therapy, and in the postmenopausal age group, continuous combined therapy. And without uterus, that is, who have undergone hysterectomy, to them we can give unopposed estrogen, because there is no uterus, so we do not have the fear of overstimulation or ovarian endometrial cancer, so we can give unopposed estrogen. And for urogenital symptoms, what to prescribe? Local estrogen. Local estrogen is sufficient for urogenital symptoms. Next slide, please. Okay. HRT in women, who should get what? So the individualization, and whom to give what and when. Okay, who? Women with menopausal symptoms. And when? At the time of menopause or perimenopause. What to give? Minimal dose. It is said that minimal dose which controls symptoms. So we have to start with minimal dose, transdermal estradiol, and estrogen alone, and tibolone, and type of progesterone. How long? For how long? For 3 to 5 years postmenopausal. Next slide, please. Okay. So, what are the key points that we have discussed so far? Is that the primary use of menopausal hormone therapy is to control the menopausal symptoms. And HRT should be prescribed for the short-term relief of menopausal symptoms and prevention of osteoporosis. And HRT should not be prescribed in the hope of protection against arterial disease or Alzheimer's disease. And oral and non-oral estrogens have different metabolic profiles that may have impact on side effects and therapeutic risk. Next slide. Next. Okay. And combined estrogen progesterone preparations have different profiles compared to estrogens alone. An increase in breast cancer is related to the duration of use and also concurrent use of progesterone. And tibolone has significantly smaller risk of breast cancer compared to estrogen and progesterone preparations. And data on HR associated risk should not be explored to women with premature menopause. Next slide, please. Next. Okay. Role of the menopausal hormone therapy. Uh, in the what is the role in natural menopausal symptoms? Then we can give hormone replacement in premature menopause, in surgical menopause, other causes of estrogen for other causes of estrogen deficiency under the age of 50 years, and menopausal women at increased risk of osteoporosis and osteoporotic fractures. And but we have to consider the contraindications and risk carefully. Next slide, please. Next. Okay. Now, as we have been talking about the hormone replacement, now what hormones to be given and what preparations, estrogen preparations and what progesterone preparations are available. Let's see. Now, natural estrogens from plants or animals. What are the different preparations of estrogens? Estradiol valerate available in 1 to 2 mg, conjugated equine estrogen, and estrone. Estrone is available in 1.25 microgram. Progestogens, the preparations are medroxyprogesterone acetate 10 mg, dydrogesterone 10 mg, norethistérone 1 mg, and norgesterone 0.15 mg. Next slide, please. Okay. Now, what things have to be taken into consideration before starting the hormone replacement or the menopausal hormone therapy? Are there any risk factors for cardiovascular disease? Is there any history of CA or venous thromboembolism? We have to check the BP of the patient, the BMI. Then we have to do some laboratory investigations, as I have already discussed. Serum lipids, smoking history. We have to screen the patient, breast screening. Then cervical screening has to be done, lifestyle advice, and documentation of the risk factors. Next slide, please. Okay. Now, this is the systemic oral hormone replacement therapy. There is a cyclical combined, as we have already discussed, to be given in perimenopause, and continuous combined after menopause, and unopposed estrogen if there is no uterus. So this thing. Okay, next slide. Okay. Now, what are the contraindications of the hormone therapy? That is, in which patients we cannot go for the hormone therapy? In patients who have breast cancer, then in endometrial cancer, untreated endometrial hyperplasia, undiagnosed vaginal bleeding, thromboembolic disease, arterial disease, active thrombophlebitis, liver disease, where LFT has not returned to normal, during pregnancy and breastfeeding, and stop 4 to 6 weeks prior to surgery if there is any surgery, if any surgery has been planned. Next slide, please. Okay. Post-menopausal osteoporosis. Now, what is the role of hormone therapy in post-menopausal osteoporosis? HRT is effective in preventing bone loss associated with the menopause, and it decreases the incidence of all osteoporosis and related fractures, including the vertebral and hip fractures. Hip fractures are very common in post-menopausal women, and it leads to very pathetic life of a woman with a hip fracture, because even after doing so many treatments, she cannot the hip replacement, be it be ball replacement or total hip replacement, does not come back to normal activity. So women at high risk of fracture, and the initiation of HRT for the sole purpose for the prevention of fractures after the age of 60 years is not recommended. The continuation of HRT after the age of 60 years for the sole purpose of prevention of fractures is taken into account, for the possible long-term effect of specific dose. The protective effect of HRT on bone mineral density declines after cessation of therapy at an unpredictable rate. Okay. Next slide, please. Okay. The risk of hormone therapy. Now, what are the risks of hormone therapy? This we have already discussed in the contraindications, and this slide it's almost the same. The risks are endometrial cancer, venous thromboembolism, breast cancer, ovarian cancer, cerebrovascular accidents, and lipid metabolism. Next slide, please. Okay. This slide is again related to the risks, and it is the data of the age in years and the study in which it is shown that HRT prescribing fell by 50% between 2001-2005, probably due to the Women's Health Initiative, which highlighted safety concerns. Risk of breast cancer returns to baseline after stopping for 5 years. Risk of ovarian cancer returns to baseline after stopping for a few years. And older women have a greater absolute risk of stroke on HRT. This seems to be dose dependent. And coronary heart disease trials are on older women, lack of evidence for younger women. Overall, the risk for younger women is probably low, and given their already low baseline risk. So this is the risk due to HRT, which again, and studies of the risk when it comes to normal. Okay, next slide, please. Okay. Okay. Menopause hormone therapy. So this is the new terminology. Earlier it was called hormone replacement therapy. And then the discussion was that why hormone replacement, as when we give insulin, as I have already said, when we give thyroid hormone, we do not say insulin replacement or thyroid replacement. So why hormone replacement? So the terminology of hormone replacement has changed to menopause hormone therapy. So low dose OC pills, menopause transition, premature ovarian failure till only estrogen in hysterectomized patients, patients who have no uterus, there is no risk, so only estrogen can be given. And combine estrogen and progesterone with patients with uterus. And the commonly used regime is conjugated equine estrogen 0.625 and medroxyprogesterone acetate 2.5 mg, and combined conjugated equine estrogen 0.625 plus norethistron 1 to 5 mg. Next slide. So this is the continuation of the earlier slide. What are the common regimens used? That is combined equine estrogen plus micronized progesterone and combined equine estrogen plus dydrogesterone. And as we have already discussed, it can be used in cyclic manner or continuous manner. And estradiol valerate 2 mg can also be used. And transdermal estrogen has been used, and there is decreased risk of CVA and thrombosis risk. And also Evalon cream, as we all know, vaginal estrogen creams are also available in the name of Evalon. Next slide, please. This is also a continuation of the slide. That is the preparations of HRT, MHT, the hormone replacement. What preparations and in what forms it is available? Tibolone, 2.5 mg per day, and selective estrogen receptor modulators like raloxifene and bezidoxifene. Then non-oral HT routes, that is transdermal, transvaginal, and next slide. Next. Okay. So coming from the hormone replacement, the other supplementations in menopausal age are calcium, vitamin D, bisphosphonates like alendronate, then complementary alternative therapies, that is herbal. And whenever patient is not fit for hormone replacement or patient refuses hormone replacement, then these are prescribed and really giving good and equivalent results. Next slide. Okay. Now, the contraindications, I think we have already discussed. Active endometrial breast cancers, undiagnosed bleeding, severe liver disease, venous thromboembolism, and the relative contraindications like migraine, thrombophlebitis, family history of breast cancer, uterine fibrosis, endometriosis, gallbladder disease. Some of these we have already discussed earlier. Okay, next slide. Okay, now when we have to stop hormone replacement, if migraine worsens, if there is jaundice, if BP increases, and as we have already discussed that if there is any surgery has been planned, then 1 month or 1.5 months before surgery, we have to stop hormone replacement. And the maximum duration for hormone replacement therapy is 3 to 5 years and up to 7 years, but better not beyond 60 years. Next slide, please. Okay. When to stop hormone replacement? General rule is to stop 1 to 2 years to see if symptoms have gone. If they reoccur, then we have to try lower dose or try different doses. Previous slide, please. Previous slide. I think you have jumped 1 or 2 slides. Previous one. Yeah, this one, yeah. And okay, then we have to stop prior to major surgery. And if started for early menopause, we have to start at age 50. Okay, next slide. Okay. Now, what will be the side effects in the first 12 weeks of hormone replacement? There may be breast tenderness and nipple sensitivity. There is increased appetite and weight gain may be there. There may be calf cramps. And patient has to go for a review in 6 months. And then first in 6 months and then annually for BP checkup, for the breast evaluation and pelvic examination. Next slide, please. Okay. Now, what are the alternatives? Alternatives to what are the alternatives that have been used? One is the tibolone, which has come up in a big way. It is a synthetic steroid with weak estrogenic, progesterogenic, and androgenic properties. Then clonidine, it is an alpha-2 agonist. SSRIs, gabapentin, then progestrogens, repellents, and SSRIs are 60% compared to 30% for placebo. And gabapentin, it reduces frequency by 45% and severity by 54%. Progestrogens may improve hot flushes, but then again the concerns are for breast cancer. Then gabapentin reduces severity but and frequency of hot flushes. Next slide, please. Now coming to the natural herbs and the remedies, which have been used in menopause, menopausal syndrome. Phytoestrogens or red clover. It has structural similarity to estradiol, but the efficacy data is insufficient. Then black cohosh, it's from the buttercup family. Flushes and other symptoms it is said to relieve hot flushes and other symptoms, but again there is insufficient data to date. And there are progesterone creams, and the acupuncture has also been tried in menopausal symptoms. Next slide, please. Phytoestrogens, it is said that the plants use phytoestrogens as part of their natural defense to control the female fertility, to prevent overpopulation and overgrazing by herbivore animals. And the phytoestrogens have phenolics, and these phenolics are isoflavones, and phenolics are isoflavones, flavonoids, stilbenes, and lignans. So that is the plant source of phytoestrogens. Next slide, please. Okay, the isoflavones are most common forms found in soya beans, lentils, and chickpeas. Lignans, they are found in bean sprouts, alfalfa sprouts, sunflower seeds, spinach, and clover. Comestans are found in most cereals, fruits, and vegetables. Isoflavones' effect on hot flushes is variable and inconsistent. Only modest and delayed improvement of symptoms and could be expected by black cohosh and vitamin E. Next slide, please. Okay. Now, how to manage a patient with troublesome menopausal symptoms using non-hormonal treatment. Now, non-hormonal treatment, first, to establish the nature and timing of the most troublesome menopausal symptoms, what the patient wishes to achieve from treatment, and whether she wishes to use pharmacological or non-pharmacological approaches. We have to inform the patient about provide information about menopause and its symptoms, that is counseling, and we have to advise the patients about lifestyle modifications. And for management of vasomotor symptoms, some non-pharmacological treatments are cognitive behavioral therapy, which can be delivered as a group or one-to-one with the help of books. And hypnosis can be offered if available. Then there is acupuncture. And if these are ineffective, then we have to offer pharmacological treatments. And pharmacological treatments in the form of escitalopram can be given, and if ineffective or not tolerated, then venlafaxine. If ineffective, paroxetine. If not tolerated, gabapentin is there, clonidine, and again pharmacological treatments after 4 weeks if possible. And both pharmacological and non-pharmacological treatments can be used together also. For managing vaginal symptoms, vaginal estrogens can be given with informed consent, and for breast cancer patients in consultation with the treating oncologist. And for discomfort during sexual activity, silicone-based lubricants can be offered, water-based lubricants are there, and topical anesthetic with 4% aqueous lignocaine. Next slide, please. How to deal with hot flushes? What are the things which can manage hot flushes? Substituting soy nuts for non-soy protein in a diet and consume 3 to 4 times throughout the day is associated with a decrease in hot flushes and improvement in menopausal symptoms. 25 grams soy protein and 101 gram egg glycone isoflavones. Next slide, please. Lifestyle interventions to improve quality of life during menopause. What are the lifestyle interventions to improve the quality of life? Let's see. Next slide, please. Okay. Lifestyle and behavioral modifications might not necessarily improve symptoms, but they bring well-being and they help the women to tolerate symptoms. What are the lifestyle modifications? Maintaining a healthy weight. Mostly women request information about weight gain and menopause. Although menopause does not cause weight gain, there is evidence that weight gain can increase the severity of vasomotor symptoms. Breast cancer survivors with post-diagnosis weight gain had a greater risk of reporting hot flushes than women who did not gain weight. So it is very important to maintain a healthy weight, because it is seen that overweight patients, they complain more of vasomotor symptoms. Next slide, please. The next thing in lifestyle modification is improving the environment through cooling, improving the cooling through environmental control. Small core body temperature elevations can trigger vasomotor symptoms. So it makes sense to propose environmental and lifestyle changes that lower the core body temperature. What changes are to be made? Adjusting clothing dress material to cotton clothes. Wear clothing made of natural fibers. Avoid fit dress like jumpers. Using a hand fan or electric fan. Keeping coolers at night. Lower the room temperature. Put a cold pack under the pillow. Turn the pillow cover to the cool side. Use dual control electric blankets. Using a bed fan that blows air between the sheets. Drinking cool liquids such as iced water. So the main motive is to make a cooling environment to lower the core body temperature. Next slide, please. How to avoid the triggers for vasomotor symptoms. Some metro class women can identify triggers for their vasomotor symptoms. We have already discussed that which are the triggers. The triggers are the spicy foods, smoking. So smoking has to be decreased or cessation of smoking, and alcohol consumption has to be decreased. So these are the triggers. So the triggers have to be avoided for avoidance of the vasomotor symptoms. Next slide, please. Several studies have investigated whether exercise improves hot flushes or not. So how does exercise helps? Exercise improves the quality of life, cognitive functioning, depression is decreased, sleep patterns, there is improved sleep if the patient exercises regularly. Then bone density, there is improvement in bone density, there is weight management. So all these benefits are from exercise, and there is reduced cardiovascular disease. So all these things, all these benefits we get from regular exercise. Next slide, please. Okay. Then cognitive behavior therapy. Group and individual cognitive behavior therapy are both effective at reducing the effect of vasomotor symptoms and at improving sleep and general well-being. And yoga, downward facing dog position, legs up the wall. Certain yoga positions, they are effective against the hot flushes. There is mixed evidence that yoga is effective for management of vasomotor symptoms and sleep disturbance. So yoga has come, the mind and body based therapies and practices in the form of yoga, they have found to decrease the menopausal symptoms. Next slide, please. Paced breathing, deep abdominal breaths where your exhale breath is a longer count than your inhale breath. Slow, deep abdominal breaths for 15 minutes twice daily may reduce feelings of anxiety that can occur with hot flushes. But this practice does not reduce the severity of hot flushes, but it decreases the feelings of anxiety. Next slide, please. Relaxation exercises. Hypnosis was more effective than an attention control comparison. Hypnosis also improves sleep and hot flushes. Next slide. Acupuncture. And small studies of acupuncture as a treatment of hot flushes have shown mixed results. Magnetic therapy, so many therapies have been recently tried for menopausal syndrome. Magnetic therapy, reflexology, chiropractic interventions, all these. Next slide. Okay. Now, medical herbs with the following active ingredients has shown promising results recently. These herbs are, one is Synecum wilfordi, another is Angelica gigas and Phlomis umbrosa. Cinnamic acid, Synecum wilfordi has cinnamic acid, Phlomis umbrosa has S-methyl ester, and Angelica gigas has dicursin and dicursinol angelate. Next slide, please. Now, we come to Estrogen 100, the formula from Shield, which has these three ingredients: Synecum wilfordi, which is equivalent to cinnamonic acid, 2.57 microgram; Phlomis umbrosa, which is equivalent to methyl ester, S-methyl ester. It is a dried root, 0.1 mg, and Angelica gigas, equivalent to nodaquinin. It is also a dried root, 1.0023 microgram. So These three are the constituents of estrogen 100, which is a which is a herbal preparation for menopausal syndrome. Next slide, please. Okay, now what are the mechanism of action, or how does these three ingredients work? The cinnamic acid, it is a natural remedy used for hundreds of years in both Korea and China. It has shown significant improvements in the quality of life for women dealing with the symptoms of pre, peri, and postmenopause. Angelica gigas, ultrafine Angelica gigas powder, it normalizes ovarian hormone levels and has anti-osteoporosis properties in oviraptomized rats. Herbal formulations composed of combination of Cynecum wilfordi hemsali, Phlomis ambrosa, and Angelica gigas extracts have been used for treating menopausal symptoms. Next slide, please. So, estrogen 100 in perimenopause, menopause, and postmenopause. How does it help? It regulates the estrogen affinity to estrogen receptors. As we have discussed in the first part of our presentation, the estrogen receptors located in different parts of the body, how they regulate the different functions in brain, CNS, vagina, in all the eye, all the organ systems. And how does estrogen regulate the estrogen affinity to estrogen receptors? It upregulates the estrogen affinity to estrogen receptors in non-reproductive target organs. So, estrogen receptors in vasoendothelium, in CNS, as we have seen, in bone, we have already discussed, in bone, in CNS, in brain, in endothelium, that is blood vessels. How does it act? In blood vessels, it reduces hot flushes, night sweats. In CNS, it improves mood swings, insomnia. And in bones, it improves the bone mineral density, so it reduces osteoporosis and osteoporotic fractures. Then it downregulates the estrogen affinity to estrogen receptors in reproductive target organs, that is the breast and the endometrium. So there is no proliferation of MCF7 cells, so there is no risk of cancer. Next slide, please. Evidences in vaginal dryness, hot flushes, mood swings, bone pain. It relieves these symptoms within 7 to 10 days. The study was conducted with estrogen 100 group, had significant reduction from 10 out of 12 Kupperman index symptoms. Next slide, please. Okay. The evaluation of effectiveness and safety of estrogen 100 on perimenopausal women for 1 year. There was a study for 1 year on the effectiveness of estrogen 100 on perimenopausal women. What does that study show? Osteocalcin, after 1 year, there was significant decrease in osteocalcin, and there was decrease in alkaline phosphatase and resultant increase in the bone mineral density. So there was improved bone health, and bone health parameters were increased significantly, and bone mineral density was significantly increased after 1 year of estrogen 100 use. Next slide, please. Estrogen 100 for 12 weeks statistically significantly improved the quality of life. 9 different symptoms were improved: hot flushes and night sweats, paresthesias, nervousness, melancholia, vertigo, fatigue, rheumatic pain, vaginal dryness in pre, peri, and postmenopausal women. No adverse events were reported. Estrogen 100 was found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. Next slide, please. Okay, and I want to add one thing as we have come to the end of the presentation. I have been using Estrogen 100 for I think 2 years or more than 2 years since when it was started. Exactly, Deepak. It was introduced how many years back? This thing I don't remember, but I have,
4 years
yeah,
back, madam.
4 years. No, yeah, yeah. It was before this thing COVID only 3 4 years. Yeah, exactly. And I have used it in many patients, and I have found excellent results. And so that was my personal experience I wanted to share. I have found very good results with this molecule. And thank you, Sheil, for giving me the opportunity to speak on this fine molecule of yours, Estrogen 100. Thank you very much.
Thank you, ma'am. Thank you very much for that wonderful and informative session, ma'am.
Thank you so
Uh,
much.
Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries that will be read for you, ma'am.
Okay, sure.
Ma'am, I have two basic questions, ma'am. Like whether
Mhm.
is there any symptoms that one is attaining or menopause early, ma'am? Is there any symptoms or any level
Uh,
value lab values
yeah.
like,
What did you ask? I didn't understand actually. Please repeat
ma'am?
your
Like,
question.
is there any symptoms that the
Oh.
woman is reaching her menopause early?
In 1 year, that means you want to say that within 1 year that she'll be attaining her
Yeah,
menopause.
ma'am. Yes, ma'am.
You want
Yes,
to
ma'am.
ask that? Okay.
Yes, ma'am.
Uh, yes, if there is irregularity in her menses, if she has irregular menses, as we have discussed, that there is a long gap, she is having her menses after 6 months or 7 months. If there is irregular menses, then we can like predict that maybe she is reaching her menopausal age. And obviously, we have to again go for all her hormones, and we have to see all the other aspects. But like the first symptom is inevitably the menstrual irregularity.
Okay, ma'am.
Okay.
Ma'am,
And
if
mm,
in case of hysterectomy, if
yeah.
the woman is undergoing hysterectomy in 35 to 40 years of age, so do
Hmm.
you recommend HRT or any other like product like estrogen, ma'am? Since they need to take treatment for a long time, so which will be
Yeah,
the
yeah.
right treatment and what will be the
Mhm.
treatment regimen, ma'am?
Yeah. Actually, since the hormone replacement therapy has been invented, so much of controversy regarding using it and what to use and whether to use or not. Initially, when it was started, it was given very it was used right and left in 97 or like that. We were not practicing then, but like we came to know from our seniors it was used very like right and left, and then suddenly came the cases of all cancers and all, then it was again stopped. So like again in the middle also we discussed about individualizing also, that
Yes,
it is tailor made and individualized. So if if you ask for my opinion, I think preparations like estrogen will be like herbal preparations will be safer to use on a long term basis. No, if you would ask me, because there is always controversy regarding the treatment. But again, like using hormones, I think better to use herbal things which has the same efficacy, and there is also decreased risk for cancers. Almost no risk as the study shows. No, so from
yes,
my side, it will be estrogen, of
yeah,
course.
ma'am.
Yeah,
Estrogen is not having any toxic effect even when they are not using
yeah,
for a long time, ma'am. So it will be a
yes,
best product
because
for
yeah,
post.
obviously, yeah. From my side, estrogen 100. Yeah.
So, ma'am, I don't find any questions in the chat box, ma'am.
Okay.
Yeah, ma'am. So, if you allow us, then we can end the webinar for today, ma'am. If
Yeah.
there is any
Yeah.
queries which is
Mhm.
reaching to us, we will be sending to you through a mail, ma'am.
Sure.
You can address on those
Sure.
queries.
Yeah.
So,
Sure.
thank you once again for being with us and spending your valuable time with us today, ma'am. I would
Thank
also
you
like
so
to
much.
thank our participants for their active participation, and I would like to thank
Thank
our
you.
Eva Care team in Assam for making this webinar possible, ma'am. And ma'am, we are looking for many more webinars with
Yeah,
you on interesting topics, ma'am. Please do
sure,
support
sure.
us. And we are
I'll
going to
be
reach
pleased.
1,000 webinars very soon, ma'am. And
Okay,
we'll be welcoming
congratulations.
you for that
Yeah,
also, ma'am. Please join with us.
yeah, sure. I'll be there.
Yeah,
Thank you
ma'am.
so
Thank
much.
you,
Thank
ma'am.
you so
Thank you
much,
very
ma'am.
much.
Thank
Thank
you
you.
so
Thank
much.
you. Thank
Yeah.
you so much.
Thank you, madam.
Thank you. Thank you. Thank you.